Well, let's go ahead and get started. I think we've got a few people on the line here. We've got some good cases for you all this morning. So anybody want to start off with this one?
Yeah, I can start this one. This is Caroline. So I thought that this looked like maybe an enucleation of something that's well circumscribed with lots of fat or adipose cells and foamy looking cells from low power.
So you favor an inflammatory process or more of a neoplastic process?
I was thinking like probably a benign neoplastic process.
Okay. Let's go back and look at a little higher magnification. So if you thought it was a neoplasm and benign, obviously you thought benign because it was kind of well circumscribed and symmetrical and all that sort of thing. What kind of differentiation do you think we're looking at here?
I think it's mostly like adipose cells with little vacuoles, like multi-vacuolated adipose cells.
Okay, so you thought these were adipose cells here.
I would thought so with all of the little vacuoles, but I may be getting off.
No, you may be right. Let's take a look at the other area. What have we got over here?
So those are adipose with, yeah.
Normal fat cells here. Okay, good. And then what are these cells here?
Let me see. Oh, like little, those are inflammatory cells.
Yeah, good. What kind of inflammatory cells?
So mostly lymphocytes.
These probably lymphocytes, these small dark cells. What about these cells that have more kind of
histiocytes?
Histiocytes. Okay, good. So when you see areas where there are histiocytes that predominate, what does that kind of
granulomatous inflammation?
Good. So now, I could see why you might think this was a neoplasm with these clear staining cells here. And I guess you probably thought these were fat cells. But is there anything else that could give you something like this?
Yeah, so maybe this is more of like a granulomatous reaction to foreign body, or you can also think of infection, like lots of things with the granulomatous inflammation.
Okay. So when you think of granulomatous inflammation, certainly infection is one thing that you would think about here. But how long would you think about that, given you've got all this kind of change here?
Not very long, probably something.
Really second, maybe. Okay. So we've got clear areas here. So the differential diagnosis is clear cells. And one is fat. You're right. Lipid is certainly one of those. What else can give you clear staining morphology in the skin? What's the differential diagnosis of that? And that's, something that when you read in textbooks and they talk about differential diagnoses, you're sort of talking about entities. They talk about like, squamous cell, basal cell, all those kind of things like neoplasms. But sometimes you need to look at the differential diagnosis of just one thing that's not necessarily an entity per se. So what's the differential diagnosis of things that give you clear staining cells in the skin?
Okay, so like I guess the lipoblasts, like
or just lipid can do it.
Okay, yeah, lipid in general.
And so you can see
cells.
lipid in like a regular fat cell. You can see it in a lipoblast, like you said. Where else can you see lipid in fat cells other than those two? What if it's like a little baby and they come in with
like paniculitis and like the neonatal?
You could see that, but also think of a hibernoma as well.
Oh,
brown fat cells.
right. The brown fat.
And those can kind of give you these little bubbly kind of morphology a little bit too. So that the mulberry-like cells. So that's just something to think about in the differential diagnosis. So what else gives you clear staining besides lipid?
I think the granular cell tumors can look kind of clear, but they look more granular than
Yeah, I agree. I don't think they're really in the classic differential diagnosis of clear cell things in the skin. But just think in terms of like the biochemistry, if you will, of things that give you clear cells. So one would be lipid or fat. What's another thing that looks white under the microscope that's not fat?
I'm trying to think. I'm having a hard time coming up with stuff. Foreign bodies, I guess some of
Yes, foreign body
are-
definitely can do it. Sure. What kind of foreign material looks clear in the skin and has lots of little bubbles?
like filler or silicone.
Silicone. Good. Silicone looks clear, and that's actually what this happens to be. All of these little tiny droplets here, these little bubbles, and some of them are inside cells and some of them are not inside cells. This is silicone,
Okay.
which is, you know, SI, you know, it's basically droplets. There's silica, which is a crystal, and that's basically glass. So if you get like you know, somebody gets an automobile accident, they get glass in their skin, they get these, you know, crystalline foreign material that polarizes. This stuff usually doesn't polarize because it's if you ever you've seen silicone, you know, like silicone breast implants, those kind of things. It's like clear, it's like an oily looking material. And people do, sadly enough, inject this into their skin for various reasons. Sometimes it's done by medical personnel in very high quality industrial grade pure silicone is used for wrinkle, you know, instead of hyaluronic acid. There's still some physicians that actually use that, and it actually works pretty well if it's done right. But then you get the people that, you know, go to Mexico, or the people that are unscrupulous, and they inject these large amounts of the silicone into their breast or their buttocks or whatever. And that stuff stays in their skin forever and migrates around and gets into their bloodstream and can lead to pulmonary emboli. And it's really a disaster when that happens. I'm not sure. That may be what happened here, because this is a huge glob of this stuff. And normally we don't see this. If you see like somebody that gets the medical silicone injections for the wrinkles, are teensy tiny little droplets, and there's little slight amounts of inflammation around there. It's nothing like this. So this could have been maybe a silicone breast implant that ruptured, but it may have been somebody that injected this stuff in a way that shouldn't have been done. But the other thing that can give you clear staining in the skin besides the lipid is glycogen. So remember glycogen, like in the outer root sheath of the hair follicle, that looks clear. A clear cell acanthoma in the skin is clear because of the glycogen. It doesn't have any lipid in there. You can get clear staining cells and things like balloon cell nevi, clear staining cells and renal cell carcinoma. So just remember, there are a lot of different things that can give you clear morphology in the skin. So just make sure you have a differential diagnosis for that. So this is this is an example of a silicone granuloma. It is interesting because it sort of does simulate fat cells. I can see why you might have thought that. Sometimes it's helpful when you see something like this to look for other things. So if you say, well, this kind of looks, and they probably would, if they had this, they might give you a multiple choice question if they threw a fat neoplasm in there. But notice you've got this really large cystic structure here. You've got these multinucleated histiocytes that engulfed some of this stuff here as well. So you wouldn't expect to see granulomatous inflammation in, say, like maybe a pleomorphic lipoma or something like that. So always look at the other features too to help you make a diagnosis. So you can see all this inflammation here, and these are not, here's normal fat, and then here's all the abnormal stuff over here. These are so-called fat microcysts. It's basically almost like emphysema in your lungs. Basically these fat cells degenerate and they sort of, empty into larger vacuoles. So these are not really lipocytes left anymore here. Okay. Everybody got that one right? All right, let's move on to the next one.
Hi, Dr. Cockerell. My name's Yelena. I'll be doing this case.
Okay, good.
Alrighty, so looks like we've got a pretty deep punch here down to the fat. Overall, the epidermis looked relatively unremarkable to me. There was some acanthosis, maybe some tabling going on. Moving down into the dermis, I did see a little bit of mucin, the kind of bluish structures, a hair follicle, and some eccrine glands. And then all the way down in the dermis is kind of where I thought most of the action was going on. There,
Only in the dermis, or is it in other
oh,
places?
sorry, in the subcutaneous fat.
Good, excellent.
Thank you. And it looked like there's a lot of these kind of like purple, brittle, shattered structures that looked like calcium to me.
Good, excellent.
And so kind of trying to decide if this is like inflammatory neoplastic, I was leaning towards inflammatory.
Good.
And kind of like the paniculitis kind of route.
Good. What's going on right in this area?
It looks like there's some fibrosis.
Okay, now tell me your definition of fibrosis. What's the definition of fibrosis?
There would be fibroblasts.
Okay, there are fibroblasts, but there's fibroblasts in normal dermis too, right? So
yes,
if it's fibrosis, what about the number of fibroblasts?
There should be more.
Yes, there should be an increase in the number of fibroblasts. Do we see an increase in this field or a decrease in this field?
Decrease. So maybe this is more like sclerosis.
Good. And what is your definition of sclerosis?
Less fibroblasts.
Okay. Anything else?
Like lots of thickened, scarred-like looking collagen.
Well, okay. Basically, we call that thickened, homogenized collagen bundles. You see how they're kind of almost, it looks almost like strawberry milk here. They're just kind of, you can't really see one fiber next to the other. They become homogenized and it really gets really thickened and leathery. And, people that have morphea and things like that, you felt their skin. If you biopsy that, that's what you see here. So this is sclerosis, which is a reaction pattern.
Yes.
And it can be seen in a number of different entities. I think we talked about a few things in one of the conferences not too long ago about all the various things that give you sclerosis. So we got sclerosis here. So that's going to narrow your differential diagnosis. And then we've got some other things that you've talked about down here. What about so this is calcium.
Yes.
What about the fat here?
The fat has like lipomembranous change. It's like feathery.
Excellent. It's got this membranous fat necrosis. Where do we see that? What is that a sign of?
That's a sign of like lobular paniculitis.
It is a lobular paniculitis, correct, and it doesn't really have much inflammation here. Usually it's seen in situations where there isn't a lot of inflammation, and it's usually associated with kind of a low-grade ischemia, if you will. So we see it most commonly in lipodermatosclerosis, right?
Yes.
Patients have chronic stasis dermatitis, and they get the Coke bottle, inverted Coke bottle type leg or champagne bottle type leg. You biopsy it and you see this, but it's not pathognomonic of that. It's basically just means that that fat has gradually died because it's not getting enough oxygen. So it can be seen in other settings also. So it doesn't necessarily mean it's lipodermatosclerosis, but it means that there's obviously something that's going on and causing that. So if you look here, we don't really see very much in the way of stasis type change, do we, up here?
No.
Got a little bit of mucin. But we've got mainly just this deep sclerotic collagen and this paniculitis with lobular paniculitis and dystrophic calcification.
Yes.
What's your differential diagnosis of that?
So I had quite a few things that I was kind of thinking about potentially, and lots of reasons why it wasn't some of these things. So something we could have thought about was calciphylaxis, but we would have normally expected to see that kind of around vessels. And it
Good.
doesn't-
Yeah, okay, that's right. Usually calciphylaxis, you'll see a little fine stippling of calcium, and you can see it in the interstitium as well. But it's not usually confined. It can be confined to the fat if you get it early. But
Mhm.
what's the other thing that you see in calciphylaxis that's not seen here?
I was thinking mainly just the involvement of the vessels, but
Yeah, good. You get thrombosis of the blood vessels. And the reason that those patients really get super sick and often die is because they get like a thrombotic vasculopathy. They get calcification of the blood vessels, they get secondary protein C and S deficiency, and then they
Mhm.
basically thrombotic vasculopathy that leads to infarcts and MIs and strokes and all that other kind of nasty stuff that they get. And there's really none of that here, is there? There's just mainly this dermal sclerosis in the lower part of the fat with this fat
Mhm.
degeneration.
Yes. With the sclerosis, something else I was thinking about was like kind of like sclerodema, because there was like mucin as well, but in sclerodema, it wouldn't like the mucin in the dermis, but not as much as the calcium in the bottom.
Yeah, you don't really see dystrophic calcification or calcification, and you don't really see that membranous fat necrosis in
Mhm.
sclerodema either. Sclerodema is kind of a misnomer in a way. It's called sclere mainly because the skin feels thick when you feel it, clinically, and then you biopsy it, and it's really just markedly thickened dermis. But there's actually no sclerosis in sclerodema. It's
Mhm.
actually mucin between those thickened collagen bundles, and it's not like lakes of mucin like you can see in lupus and GA and some of those things sometimes. It's like a fine amount of mucin between the individual thickened collagen bundles. And you can take a punch biopsy of sclerodema and bury it all the way to the plastic, and you don't even get into the fat. So it's
Mhm.
really not sclerotic, interestingly enough. So it wouldn't really have the sclerotic collagen that we see here in sclerodema. And you don't get
Mhm.
the fat changes. But what
Mhm.
else can give you this pattern?
Another thing I thought about potentially was like pancreatic panniculitis, but in that I would have expected more of like the saponification kind of
Good,
look.
good. So you wouldn't see the membranous fat necrosis change that you see here. You see that saponification where the individual fat cells, they almost look like cells of like a splinter. They form little small, boxy type cells because the
Mhm.
individual fat becomes, you're right, it actually forms a stearate. It's calcium stearate that forms inside the individual lipocytes, and it sort of calcifies and looks like a little tiny bar of soap, if you will. So this isn't really saponification. This is more, like you said, dystrophic calcification here.
Mhm. And then kind of along that route, potentially also calcinosis cutis. But for that, I would expect the calcium deposits to be more in the dermis and not in the subcutaneous fat. Although I guess they could potentially be in the subcutaneous fat as well.
Yeah, and again, that would be more calcinosis cutis is either just kind of idiopathic calcification that happens for unknown reasons, like scrotal calcinosis, that sort of thing, or it can
Mhm.
be related to trauma, something like that. But it usually, if it's dystrophic calcification, that's really a form of calcinosis cutis. That's kind of almost like a generic term. So
Mhm.
here we've got other features than calcification. We've got sclerosis, we've got fat degeneration, and we've got
Mhm.
dystrophic calcification. And then we have some things that we don't see, that is, the vascular thrombosis and things like that we might want to look for calciphylaxis.
Mhm.
But the sclerosis is an important point here, I think. So when you
Mhm.
see sclerosis, you should be thinking in terms of, well, what diseases give you sclerotic collagen? And
Mhm.
there's not a ton of them. There's not like, 100. There's probably only about 8 to 10. So what are some of the diseases that say, well, let's just forget about this for a minute, and let's talk about things that give you this sclerotic collagen in the lower part of the dermis here? What are some diseases that can do that?
Morphea is one.
Morphea and the diseases in scleroderma, that whole family, progressive systemic sclerosis, mixed connective tissue disease, those conditions, and then overlap conditions of those, right? Where let's say you have scleroderma and dermatomyositis together, maybe scleroderma or morphea and lupus together. So maybe an overlap between the two. So would that possibly be an explanation for something like this?
Yes.
It could be, right? So morphea profunda, which means morphea where you get the deep involvement, you don't necessarily get the overlying superficial dermal involvement, can get into the subcutaneous fat. Usually it doesn't give you this fat degeneration, the dystrophic calcification like this. So to me, this probably isn't just pure morphea. It's probably some type of an overlap, maybe between lupus and morphea. You know, it's probably kind of a combination of different connective tissue diseases here. And, you know, if you see the lobular paniculitis with fat degeneration, not usually the membranous fat necrosis, but more kind of that hyaline pink fat necrosis, you maybe think about lupus erythematosus profundus. But this was an example based on the clinical information we had here, an example of a deep variant of morphea that just also had lobular paniculitis with dystrophic calcification. And we know that patients with morphea and crest, things like that, they can get calcification. So you can get dystrophic calcification in connective tissue diseases fairly commonly. Dermatomyositis can get it, crest, obviously. So basically, this was an example of morphea that had morphea profunda with paniculitis and dystrophic calcification. So it's a very interesting biopsy. I think the most important teaching points is just to understand when you see this sclerotic collagen, to have a differential diagnosis of things that hone you into that. You probably would not see something like this on the board examination because it's too esoteric, but it's an interesting example of morphea where there was also morphea paniculitis that was more lobular with dystrophic calcification.
Gotcha. Thank you so much, Dr. Cockerell.
It's an interesting biopsy, but yeah, you're not going to see that exact thing on the board, but at least now you can, you know, got a good differential for sclerotic collagen. Okay, who wants to give this one a go?
Good morning, Dr. Cockerell. It's me, Ellie. I'll be doing the next one. So here, it looks like we kind of have an excisional biopsy maybe that fell apart. Because you have this piece of epidermis and dermis, but then there's kind of this other like nodule on the side.
What part of the body are we on here?
I believe we're on an acral surface.
Good. Excellent. We certainly are. Acral skin, thickened epidermis here with a markedly thickened cornified layer, lamina lucida, thick granular layer. So we're on volar skin. And then you're right, the main findings are over here.
Yeah,
so you can kind of imagine it may have fallen apart, but it may have fallen apart at the time of the procedure.
Yes. So we have this from inflammatory or neoplastic. I was thinking this was a more neoplastic process because we have a very well circumscribed nodule of what looked like spindle cells.
Good. So, and it's obviously, do you think this is benign or malignant, just based on what we have here?
Benign.
Yeah, benign lesion, very small, round, papular lesion, and neoplasm. And so do you think it's an epithelial or non-epithelial neoplasm?
Non-epithelial.
Good, non-epithelial. Now, when we get into the non-epithelial things, what are some of the things that you start thinking about here?
So like fibrohistiocytic things like
good,
like fibroblasts and smooth muscle cell.
Good.
Kind of what I was leaning towards for this slide because of the nuclei. They kind of reminded me of like the cigar-shaped nuclei.
Yeah. Okay. We'll look over here. That I agree. That looks pretty blunt, cigar shaped. Some of them kind of have a stellate morphology to them. So when you see that, yeah, that favors fibrohistiocytic differentiation. And then what about this material in this area?
It's just kind of like wispier.
Yeah, those are collagen bundles.
Mm-hmm.
They're really closely, densely packed together, and they're kind of almost becoming kind of homogenized in a way. So you can imagine this thing is beginning to form kind of a nodule. It's losing its cellularity. It's kind of, probably at one point, if we would have biopsied this, maybe say a couple of years, and previously it would have had a lot more cells. And then now as time has gone on, it's pretty much kind of turned into this really thick, collagenous nodular papule, if you will, here, subcutaneous lesion.
Mhm.
And there's mucin left in the background.
Yes.
So what's your differential diagnosis of this?
Yeah. So I also kind of appreciated that there seem to be some like vascular structures as well. So
Yeah.
I was favoring angioliomyoma,
Okay.
but within that differential, there's also, things like dermatofibromas or neurofibromas. But if we're saying this is smooth muscle cell, those would be less likely.
So you think this is all smooth muscle here?
I did, yes.
Let's look at the edge here. What about these cells over here? Do those look like smooth muscle to you here?
Not as much. The nuclei don't have that same kind of appearance.
Right. So they look again more like fibroblast here, and they blend imperceptibly into this area. There's a couple of blood vessels here, and these are probably there's a few. But if you look at an angioliomyoma, you're going to see many blood vessels there, and you'll actually see the smooth muscle bundles at the coming off of, if you will, the blood vessels. So here we just got all of these sort of densely packed homogeneous collagen bundles here with residual fibroblasts and a few blood vessels, but not very many. There's some small, little small capillaries. So what else do you think about it? Let's say that we did say a smooth muscle actin stain and it was negative. Well, it can't be smooth muscle. So what else can do this?
So if we're saying that are we saying that our fibroblastic or our fibrohistiocytic cells aren't smooth muscle?
Yes, those are not smooth muscle. They're actually, if you have myofibroblasts, you can have a little bit of, smooth muscle component inside those individual fibroblasts, but all of this stuff here would not stain positively for actin. And if it was a smooth muscle like a leiomyoma, just light up the room when you do a smooth muscle actin stain on it.
Okay. So other fibrohistiocytic things.
So remember, we are also, we're on volar skin.
Okay.
It's not really painful. Like if you were to reach and touch an angioliomyoma, that's going to be painful.
Yeah.
So the non-painful tumor. And it's not really good for dermatofibroma, but it's in the family of the fibrohistiocytic lesions. This isn't something we think about a lot in dermatology, but it is something that we encounter. And I believe there's actually an article in one of Dr. Warren Heyman's articles that he writes about in JAD every month about this not too long ago.
Not really seeing a lot of inflammatory cells either.
No, it's really not so much inflammatory. It may be considered inflammatory if you consider fibrohistiocytic proliferations to be inflammatory. Well, this is an example of a plantar fibromatosis, like it's analogous to Dupuytren's contracture.
Okay.
So this is one of the fibromatoses. And you do need to know about this. They could ask this on the exam. Mainly, if Dr. Heyman writes about it in JAD, it's going to be fair game for them to ask a question about it on the exam. So make sure that you know what this is. And so tell me a little bit about what you know about the fibromatoses. What's kind of important about them? So we obviously have the Dupuytren's contracture, which, affects a lot of people, and you get plantar fibromatosis. They can get plantar fasciitis sometimes associated with that. But are there any other settings where you see fibromatoses that might be important from a syndrome perspective?
Oh gosh. One is not coming to the top of my head. I'm sorry.
Well, Gardner syndrome.
Okay.
Desmoid fibromatoses there, plus cysts, and obviously colonic polyps, autosomal dominant process. So that's something, and that can present in the skin on occasion. Patients with Turner syndrome. They get the webbed neck and all that kind of stuff, torticollis. If you biopsy that, you can see evidence of fibromatosis-like change. Peyronie's disease, biopsy that, shows fibromatosis. So this is another type of pathologic process where you get fibrohistiocytic proliferation and excess collagen production. It's kind of analogous in some ways, not exactly, but it's sort of in the family, if you will, of things like morphea and scleroderma, where the main problem is too much sclerotic collagen versus things like where there's atrophy or a lot of inflammation and whatnot. So here you've got an overgrowth of these fibroblasts that produce too much collagen and then lead to contracture deformities and things of that nature. So just remember, this is in the differential diagnosis. This is what this is here. And the other thing that you can also see is like a giant cell tumor of tendon sheath or a fibroma of tendon sheath. If you biopsy those early, you'll see fibroblasts, osteoblasts, osteoclast-like giant cells, and fibrosis. And then as time goes on, those cells kind of gradually go away, and you're kind of left with this sort of change here. So that's basically in the family of these fibromatoses. So, I don't think you need to become a soft tissue tumor expert, but just make sure you kind of know about this entity. And this is what you have to do to get the biopsy. If you have to take a deep incisional biopsy because you do a shave or punch, you're probably not going to get the lesion.
Got it. Thank you.
Okay, great. All right, we'll get back to some more conventional.
I can take this one, Dr. Cockerell. So
Great.
looks like we have a punch. Kind of just from a low power view, there's an inflammatory infiltrate in the superficial dermis and a pretty big granuloma in the deep dermis.
Okay, good.
Seems to be pretty well organized. There's some maybe some caseating necrosis in the middle.
Maybe?
Yeah, there is. Yeah. And
yeah, if you want a good example of caseation degeneration to teach your medical student colleagues, this is a perfect example of it.
And definitely, so kind of looking a little bit closer, there look to be lots of kind of neutrophilic dust, so lots of neutrophils around the area. And then kind of around mostly kind of lymphocytes, and you can tell it's pretty organized as a granuloma because there's a band of fibrocytes around there. So it's definitely working on kind of walling it off.
So when you say organized, you mean that like the host is trying to sort of wall something off, build a fortress around this thing and get rid of it. I think that's kind of what you're meaning with that. Okay, good. Yeah, and there's some fragments of cells in here, but I didn't see all that many neutrophils. It's interesting. Most of these are lymphocytes and histiocytes here, and there's a subtle. There's kind of a teaching point to that as well. What's your differential diagnosis of this pattern here?
So for caseating granulomas, you'd think of infective granulomata. You could think of cutaneous TB, some of the deep fungals.
Okay, so let's talk about those two, for example. If you're going to place a bet with your attending physician, if he sees this slide here, what are you going to bet on? AFB or fungus here, and why?
I would say AFB.
Okay, why?
Just because of I think the caseating necrosis, I think with cutaneous.
That's number one. Yes, you're right. That's far more common in atypical mycobacterial infections. What's the more common pattern with deep fungal infections?
A non-caseating usually, or just kind of a deep inflammatory infiltrate?
Well, they usually give you more of a suppurative granulomatous dermatitis, lots of neutrophils with multinucleated histiocytes, much more brisk inflammatory reaction. And then usually they're seen kind of up in this area with marked pseudoepitheliomatous hyperplasia. So this is a better pattern for atypical mycobacterial or cutaneous tuberculosis. Now, there's one type of TB that can give you more of that suppurative granulomatous process with pseudoepitheliomatous hyperplasia. Do you know which type of TB that is?
No, I do not.
Okay. It's called tuberculosis verrucosa cutis, which is a pretty good name because verrucous changes will give you that pseudocarcinomatous hyperplasia. And if you biopsy that, you commonly do see more of a suppurative granulomatous reaction. In the old days, they actually used to talk about the so-called tuberculids. I remember my granddad, he was a dermatologist years ago, he used to talk about the tuberculids. And, the idea was that it was probably more of a reaction to the AFB rather than the actual AFB causing the inflammation. And so like, there's probably some truth to some of that, especially we talk about erythema induratum, nodular vasculitis being in some cases a reaction to an AFB infection, erythema nodosum leprosum, a reaction to the leprosy. They don't have to have organisms in those areas. So you can get secondary inflammatory reactions in patients that have infectious diseases. Syphilis, you can get secondary inflammatory reactions, and they don't have to have the spirochetes in those areas. The Jurij-Herxheimer reaction, for example, those kind of things. Those are reactions to the infectious disease. So this is, probably not a tuberculid. There may actually be organisms in here, but this is a better pattern for an AFB or like, cutaneous TB. And notice that there's not that many neutrophils here. It's actually mostly lymphocytes. There's a plasma cell, there's histocytes, and then the caseation degeneration. Now, it's important to recognize the caseation degeneration and not to confuse that with the central fibrin, for example, in rheumatoid nodule, or the central collagen degeneration that we sometimes see with Necrobiosis Lipoidica or subcutaneous GA, where you can get some mucin and some degenerated collagen sometimes. So you got to recognize that these are actually histiocytes that are dying and breaking down with possibly some degenerated collagen. So that's caseation degeneration and not palisaded granulomatous dermatitis. So you're right. That's what you would think about. Anything else you would put in the differential diagnosis? Is there any other inflammatory process where we see caseation tuberculoid granulomatous inflammation?
Well, I know like you can get like acne, agmenata, sometimes late, like.
Tell me about acne agmenata. What do you mean by that specifically?
So it's kind of like usually like a deep caseating granuloma, and I was reading it can happen from like zirconium or kind of other
Yeah, those are more of the foreign body granulomas, but there is acne granulomatous rosacea can give you tuberculoid granulomatous inflammation. That's in the acne spectrum. So that actually can give you this, usually not this deep, large granulomatous inflammation like this, usually little smaller areas, but you'll see little granulomatous inflammation up here around follicles. And the differential diagnosis of granulomatous rosacea is sarcoid clinically, but if you see the caseation degeneration in the small tuberculoid granulomas, you should think that it may be granulomatous rosacea. And then, you're right. You should think about a foreign body here. And so you can polarize it. In this case, it happened to be negative. And then actually here we have a gift for you. We actually gave you a special stain.
Yeah, Fite stain. So
how did you know it was a Fite stain?
I would kind of assume it usually there. I tried looking through it, and there's usually some highlight of like the pink areas. I think those were a little bit of just.
What's the color of a Fite stain?
So it's usually I think it'll populate like acid-fast bacteria pink.
It does stain the acid-fast bacilli, and it'll stain them reddish if you see them, or usually red if you actually are red snappers. But if you do the Fite stain, it looks like this. It's blue. It's a blue stain like this. So you can see it's got this bluish color. It kind of depends on what the counter stain is. Some Fite stains have a green counter stain, so they're either blue or green. But this one's got, ours in our laboratory has more of a bluish morphology. And if you're going to look for the organisms, always look in the caseation areas, and look, you got to kind of search around. Then you want to look in the granulomatous areas here as well. And it's what we call going on a bug hunt, and you have to sit here and look for it for a while. I believe there were organisms in here. It's not as easy to see on the scanned image. I know we saw them because we made a definitive diagnosis in this case. Did you guys were able to find them in here?
I wasn't able to see any, but I know sometimes there can be very little.
There can be. In fact, you're surprised. Sometimes you'll see an infectious granuloma like this, and you might see one organism. And you say, well, gosh, you should think you see quite a few organisms, given that it's an infectious process, but you may not. You may only see one or two. So I don't see them here either. And we could spend the next 10 minutes scrolling around trying to find one. But I would say go back and look, and you probably, if you look carefully and spend some time with it, you'll probably find one, because this definitely was an AFB infection. So it's a good example of that. It's a good example of caseation necrosis. Remember, the differential, it looks better for AFB when it's got this caseation pattern as opposed to a deep fungal infection.
Okay, thank you.
You're welcome. Okay, who wants to give this one a go? This one has a gift with it as well.
Good morning, Dr. Cockerell. I'll do this one.
Okay.
Okay, so this looks like a punch or maybe an excisional biopsy. We're going all the way down to the fat.
Yeah, I think it was like a 6mm punch, but yeah, they did a really good biopsy. We love biopsies like this. They give us the ability to assess the size of the lesion, the depth of the lesion, which is important here. If we just had a shave, we'd sort of be in trouble.
Yes. So we're going all the way down to the fat and looking at the cells. It looks like these sheets of purple, blue cells down in the dermis, all the way to the fat. If we try to give it a pattern, I'd say nodule and diffuse, but I do think this might be a neoplasm too.
It is good. It's a neoplastic process. It's got a nodular pattern. What kind of cells do you think we're dealing with at this power?
They seem pretty, when I was looking at them closer, kind of atypical.
Well, yeah, we'll be able to tell about the morphology, but at low power, what kind of differentiation do you think we're dealing with here? Epithelial or non-epithelial?
Oh, non-epithelial.
Yeah, and then if non-epithelial, is it vascular? Is it fibrohistiocytic? Is it neural? Is it muscle? Or is it something else?
I thought it was more maybe bone marrow derived.
Good,
So,
good. Yes, absolutely. Lymphoid, somewhere in that category. Good.
yes,
And do you think it's benign or malignant based on this pattern?
I would say malignant.
Yeah, you're right. So what are we dealing with, basically?
I was thinking some type of lymphoma.
Yes, we're dealing either with lymphoma or something in the hematologic lymphoid category. It's bad. We don't like this. Not good. So we're going to higher magnification. Now, is there anything at this power that, and this is more sophisticated, subtle dermatopathology fellowship type levels. You don't really have to know this, but when you see these sort of large nodular aggregates that are kind of teardrop shaped like that, it's a pattern that we often see in some of the cutaneous B-cell lymphomas. Now, this is not a cutaneous B-cell lymphoma this time. I'm just going to tell you that. But when you see that sort of teardrop, large nodular aggregates at low magnification, say, well, this is a lymphoma, it doesn't look good. Maybe a B-cell lymphoma. It doesn't have the classic pattern of MF or, that sort of thing. This kind of looks like maybe possibly a cutaneous B-cell lymphoma or something like that. Okay, and it also looks more primary. Usually if you get secondary cutaneous involvement from a lymphoma, it tends to give you more of a diffuse interstitial pattern, and that can be diffuse with lots of cells. It makes the entire thing look like it's involved, or it can look almost kind of like cords and strands of cells. So we see this sort of pattern like this. It says it's probably primary, could be a B-cell lymphoma. And then we're going to higher magnification, see if we still agree with that. And let's take a look. And now, what kind of cells do you think we're dealing with? Notice one other thing about this. There's no germinal centers here. So again, at low power, you might say, well, it looks like a B-cell lymphoma, but there's no germinal centers. If we're thinking of a germinal center like B-cell lymphoma, we might think of follicle center cell lymphoma. This doesn't have the germinal center cells. This is just diffuse involvement with these very, very darkly staining pleomorphic cells here. And does it have any other kind of morphology to you that's sort of helpful at all? And this is more, I'm not going to expect you to pick this up, but these sort of have a very primitive blastic type morphology. So it doesn't really, we look at this and say, this just looks primitive. It doesn't look great. And there's some scattered mitotic figures here. If you look carefully at some of the cells, and one of the reasons I wanted to show you guys this is because it's kind of a hot topic right now and might end up on the board examination. Some of them have a little bit of a plasmacytoid morphology. They don't look like plasma cells, but if you look at the cell right here, it's kind of got a clock face sort of chromatin pattern to it, and it's got a little rim of cytoplasm around it. You don't see that in a lymphocyte, right? Lymphocytes are just basically no cytoplasm. They're just all nucleus. So here we've got some cytoplasm around it. So it kind of looks like quasi-plasma cell-like, but not a classic plasma cell. So we say plasmacytoid. So do you have any idea what the diagnosis is here?
So I was thinking blastic plasmacytoid dendritic cell neoplasm.
And that's what it is. Good. That's exactly what it is. Now, why did you think that? Did you think that because of the special stain we give you also?
That definitely gave the hint.
Good. Yeah, and this is sort of a hot topic. Why is it a hot topic?
I think there's a new drug that was
There is
approved.
a new drug for this. What's the 5-year prognosis survival of patients that present with this tumor untreated?
I believe it was like 14 months median survival.
Yeah, they
This-
die. This is a
Yeah.
bad lesion, as you can tell. And it's not really a lymphoma. It's actually in the family of the hematologic. It's almost more like an AML type of tumor. These cells, and this stain is the CD123 stain, and that's classic for this lesion. And CD123 cells are also seen in inflammatory processes. Also, you've seen in lesions of lupus. You've seen them sometimes in lichen planus. So CD123 marker positive cells, they kind of live in the skin, and they kind of get recruited and become more prominent in certain inflammatory conditions, but not like this. You've got a diffuse involvement where you get lots of these cells like this. And there's a couple of other cells that stain positively for this too. You know what those are as well?
I think there's some other lymphoma, maybe there's a B cell lymphoma that you can see this positive for.
Well, actually, this is an easy one to remember because it also stains positively for CD4
Oh, sorry, and CD56.
and CD56. So even a first-year medical student can remember this. It stays positive for 1, 2, 3, 4, 5, 6. In fact, when they asked me to kind of start talking about this for them, when they wanted to promote their drug that can treat this rare tumor that we hardly ever see at all, but does happen in dermatology because they present in the skin. I said, hey, you guys need to use the mnemonic that this stains for 1, 2, 3, 4, 5, 6, so we can remember this because it does. And what do these lesions generally present like in the skin? What are the two main cutaneous presentations of this neoplasm?
Either as nodules or
Good.
a non-healing bruise.
Excellent. Good. So you're on top of this. So that's good. That's really 90% of what you need to know about this tumor. Then probably the most important thing from a dermatology perspective is that we recognize it when it comes in as sort of a weird non-healing bruise. And I've seen several of these lesions. And when you see that, think about it, take a biopsy of it, and then make sure that the dermatopathologist, thinks about it too, and that they order these special stains, because sometimes it can kind of look more like a plasma cell lesion. I've seen some that look more like a plasmacytoma. We just had one in our laboratory just about a month ago that really looked more like a plasmacytoma, and we sent it in and worked it up, and sure enough, it was positive for these markers. So, and that's, plasmacytoma has got a much better prognosis than this lesion. This lesion's got a death sentence if you don't treat it. But if you treat it, they get almost all of them respond to the treatment initially. It's got a dramatic response to this biologic that targets these CD123 cells. And so you want to make sure that you get them diagnosed and treated as soon as possible, as you save the patient's life. So you may see that on the exam because it's kind of a hot topic, and they might ask you about it.
Thank you.
You're welcome.
Hi, good morning, Dr. Cockerell. This is Annie. I can take this one.
Okay.
So we have a lot of fragmented, scattered material, possibly was an excision.
Or maybe like that other lesion we had earlier from volar skin, like this.
Yes,
also.
we got a good hint in the left corner, at the fixed tram corneum, so we know we're in one of the acral surfaces. Just looking at it from lower power, I see all these sheets of cells. I was thinking neoplastic category.
Good.
See kind of these like slits like punctuating these sheets of cells. So thinking like possible glandular, so epithelial differentiation.
Good. So epithelial, glandular, good. So you're moving right in the right direction. Near volar skin. Okay.
Yes. So some of the glandular glands kind of, I think it was near top, have a little bit of the decapitation. So I was thinking more of the apocrine lineage versus ecrine.
I agree with you on that. Good.
And then there's some on closer magnification, the cells look a little bit pleomorphic in some areas. And then in some areas too, we kind of see more of like the papillary projections.
maybe some a little bit of pleomorphism here, but not, don't see very many mitotic figures or anything like that necessarily.
Mm-hmm.
But you've got a large lesion that's got multiple aggregations in here, correct? And you've
Yeah.
got some areas that are solid. There's a mitotic figure here, and then you've got the areas that are glandular. Okay, so do you think this is benign or malignant?
I lean towards malignant just given the size of this lesion, all the sheets of cells we have.
Good, excellent. That's exactly right. So you don't necessarily have to have a lot of pleomorphism, a lot of mitoses, a lot of striking atypicality for certain lesions to be malignant. If you look at a dermatofibrosarcoma tuberans, for example, you may not see one single mitotic figure in that lesion or atypical cells or whatever, and that thing can be obviously is a lesion that can it's locally aggressive, but it can degenerate into a fibrosarcoma. So again, that's a malignant lesion also that doesn't have to have a lot of atypia. So here, the malignancy is largely because of the large size. We can't really assess the symmetry, the circumscription. It seems like it's probably poorly circumscribed. So yeah, most likely malignant. So what's your diagnosis in this case?
Given its location and that it's likely malignant, this could be something you have to rule out is a digital papillary adenocarcinoma.
Good. This is exactly what this is. This is aggressive digital papillary adenocarcinoma, and it's kind of a wolf in sheep's clothing, if you will, because you don't have to have a lot of atypical cells. You don't have to have a lot of mitoses. It's really diagnosed on a malignant basis based on the asymmetry and the fact that it's often large, like you see here. So you don't have to have a lot of mitoses. And even though it's got a bland cytology, it metastasizes fairly commonly, and it can actually kill the patient. It can be fairly aggressive, even though it doesn't look all that atypical under the microscope necessarily. So it's a good lesson to learn. So you're exactly right. That's exactly the way to work this up. I'm not sure what they thought this was. They might have thought it's a glomus tumor or something. And so they did kind of like an incisional / enucleation biopsy here. And that's why it's all fragmented. We got all these multiple aggregations. They didn't do, and a lot of times you get these subungual acral lesions. They're not so easy to biopsy unless you take sort of a broad incisional type biopsy to really get it out as in an en bloc fashion. So you'll see guys will take shaves and they curette the base and things like that. So this is commonly what we get here. So we don't really see a classic nice example like the last one where we're going to punch biopsy of a lymphoid lesion. So this is an aggressive digital papillary adenocarcinoma. One other pearl about biopsying lesions like this: always think about taking an X-ray prior to the biopsy. Dick Scher used to teach us nail pathology and nail dermatology back when I was a resident, and he used to always emphasize that point. Take an X-ray first, because this may be coming for the bone. You kind of want to see what you're dealing with. So before you do a nail unit biopsy, get up a regular plain film first, and bring it back in a week after you get that, and just see what you're dealing with. That definitely can help you before you biopsy a nail unit lesion.
Good to know. Thank you, Dr. Cockerell.
You're welcome. This is a really good one also. Beautiful.
All right. Looks like we have a very nice squared looking punch biopsy.
Good.
Just at low power, looks like the epidermis is pretty normal. Maybe a little bit of scant infiltrate at the superficial dermis, but most of it looks like it's a little bit deeper in the dermis. So I'd be in the superficial and deep dermatitis differential category.
Good.
The most striking feature, I think, is how thick and dense the collagenized dermis is.
Okay.
Looks
we
like
just talked a little bit about
uh-huh.
collagen a few minutes ago. Do you see something analogous to kind of what we saw before?
Yeah, it looks very almost, I would be in the sclerotic differential once again. It looks very hypertrophied.
Excellent. Good. Sclerotic collagen. Now let's take a look and see if there's anything else about this lesion that's different than the one we saw before. What kind of cells do we have here?
Lymphocytes?
There's some lymphocytes here, but look carefully here between these collagen bundles here. What kind of cells are these?
Fibroblasts.
Some are, but what are these cells over here too? that have a little bit more cytoplasm in them?
Plasma cell.
Well, there are plasma cells, in it, especially down in this area.
Right.
So anytime you get sclerotic collagen at the periphery of the sclerotic collagen in the fat, you're going to see plasma cells. So that's very common. You see that in Morphea, any of the scleroderma conditions, you see that. But you have these other cells here that are between and among these collagen bundles that are with some abundant cytoplasm within them. Remember the first case we had today?
Mm-hmm.
So what are these cells?
The histiocytes.
Yes, we've got histiocytes. So we got histiocytes between and among these collagen bundles up here, attempting to form a type of granulomatous inflammation.
Hmm.
Now, when you get histiocytes between and among collagen bundles, what kind of granulomatous inflammation we call that?
Not sure.
Palisaded granulomatous dermatitis.
Oh, right.
Palisaded granulomatous dermatitis. So what condition do you know that gives you palisaded granulomatous dermatitis, palisaded
Mhm.
histiocytes between and among collagen bundles like this, plus sclerotic collagen in multiple different sort of, quote, layers, if you will.
Uh-huh.
Here's one there. And this one, you've still got, then I've got the plasma cells here at the bottom of the sclerotic collagen that kind of goes along with this. What disease do you know gives you palisaded granulomatous dermatitis with degenerated collagen and sclerotic collagen in the center of the palisade?
I would think of sarcoid.
Well, sarcoid gives you sarcoidal granulomatous dermatitis. This is palisaded. So remember the three main palisaded granulomatous dermatitis: granulomedullary, rheumatoid nodule.
Oh,
and
necrobiosis lipoidica.
Necrobiosis
The
lipoidica.
tiramisu layers.
And we've got here. This is an example of necrobiosis lipoidica in a relatively late stage. Here's the palisaded granulomatous dermatitis over here. Here it is over here. And then we've got lots of degenerated thick sclerotic collagen, which is what you see in the latest stage of NLD. So this is a beautiful example. So this is where you've got, when you see those patients that come in and have that yellowish, appearance, and it feels really thick, and their pretibular area gets really tight and all. Well, it gets tight because it becomes sclerotic. It's basically, you get sclerotic collagen in the pretibular area. It can be from lipodermatosclerosis, it gets sclerotic. You get it from this, it gets sclerotic. Sometimes you get morphea in that area, it gets sclerotic. So here's this, it's the same reaction pattern, but here it's associated with the palisaded granulomatous inflammation, as opposed to just being the sclerotic collagen like we saw in the morphea case earlier.
Mhm.
So this is NLD in this case. So it's a beautiful example of that. And it also gives you that squared biopsy. So if you see a squared biopsy, low magnification, think, hey, that collagen is thicker than normal. Normally you take a biopsy, and because of the elastic fibers, it just kind of contracts, and you got the epidermis is out here, and then it sort of almost looks like a little, it gets thinner here rather than staying the same thickness. So yeah, that boxy squared appearance makes you think that collagen is too thick, too sclerotic in a way. And then you use these other clues, and you see the granulomatous inflammation up here. And notice these collagen, these histiocytes are between and among the collagen bundles. That's just one of the ways that palisaded granulomatous inflammation really develops. And here you've got it forming this so-called layer cake morphology. Okay, did you guys think of that, hopefully?
I did not.
Well, good. It's a good example of it. So now you can go back. Anytime you
Yeah.
get sclerotic collagen, you get plasma cells too. So don't let that throw you off either. That's just a very common reaction pattern. Okay, why don't we stop there, and we'll save the last one for another time. So thank you guys for your participation, and Happy New Year, and we'll do another one here next month.
Thank you.
You're welcome.